So we're going to pick up with the next presentation on cost effectiveness related to herpes zoster vaccine. Dr. Leidner.
Hi, my name is Andrew Leidner. I'll be presenting an overview of two economic models that assess the cost effectiveness of herpes zoster vaccinations. So just to say thanks to the collaborators, this is a presentation of work that was conducted outside of CDC by two teams, one team at GSK, one team at Merck, and there was a lot of review at CDC and in the ACIP Workgroup, all of whom helped me put these slides together. So I appreciate their help. As the reviewer and presenter, I have no conflicts of interest to declare. So as a roadmap for our discussion today, I'll be presenting a few fundamental aspects of cost-effectiveness models, followed by a background of the two models that we're talking about in particular, then followed by some base case results. And I'm going to bring up some base case results fairly early because the two models do have some important differences in their results, and the middle section of this talk will be about where those differences are coming from. And then we'll conclude with a discussion of overall cost effectiveness results from both the models, and then I'll provide a summary and then a discussion of some limitations. My objective in this presentation is to describe two cost effectiveness models which were developed by two different teams, Merck and GSK. There is another cost effectiveness model in the works by a CDC team, and those results will be presented in the next meeting in October. A cost effectiveness ratio can be considered a price paid per health unit gained. And health unit, in some of these models, it will vary. One very common one is a cost per case avoided. In this case, we'll be talking about costs per quality adjusted life year gained. And a QALY, as it's abbreviated, is suitable to herpes zoster because QALY accounts for morbidity loss, and the main disease burden of herpes zoster is in pain, which is a morbidity outcome. Final note on cost effectiveness ratios is that they always compare two potential strategies. So in this little green box, we're comparing a vaccination strategy to a no vaccination strategy. You could also compare vaccination with vaccine A versus vaccination with vaccine B. And throughout the presentation, I'll be using this notation of strategy 1 versus strategy 2 to define our scenarios. The cost effectiveness ratio is a result of calculations based on assumptions, or you could also call these assumptions parameters, or you could call them inputs. The assumptions combined with how they're calculated together is the cost effectiveness model, and the output of that model is the cost effectiveness ratio. Parameters can include many things related to the disease system. Intervention effectiveness, in this presentation we'll be mainly focusing on vaccine effectiveness, but also cost of the intervention, cost of disease outcomes, and others. An important aspect of these two studies is that data varies based on the parameter that you're focusing on, and this will come up later. As one quick concrete example of how cost effectiveness ratios work, you can imagine intervention A has a cost effectiveness ratio of $1 million per quality adjusted life year, and intervention B has a cost effectiveness ratio of $10,000 per quality adjusted life year. If this were the case, you would say intervention A is less cost effective than B because with A you pay $1 million for one QALY, and with B you pay $10,000 for one QALY. Moving into background on the model and some base case results. So the current vaccine that's licensed and recommended is Zoster live attenuated vaccine. We've been abbreviating it ZVL. I'll be referring to it as the live vaccine. It's a single dose vaccine. It's been received by 20 to 25 million people. The candidate vaccine is a herpes zoster subunit vaccine. It's a 2-dose vaccine. I'll be referring to it as the subunit vaccine, but it'll be abbreviated as HZSU. So as I've said, there's two models we're talking about today, the GSK model and the Merck model. and then the CDC model is forthcoming. So the research questions that were focused on in this presentation from the GSK model and Merck model are as follows. Looking at adults 60 years old and older who've never received the herpes zoster, who've never received a vaccine for herpes zoster, what is the cost effectiveness of the live vaccine versus no vaccine, the subunit vaccine versus no vaccine, and then the subunit vaccine versus the live vaccine. And this last one, the subunit versus the live, I'll refer to that as the head-to-head. But these three scenarios are important to remember. We'll be referring to them throughout. And the majority of our attention will be focused on the subunit versus no vaccine scenario. And also just to say, both models did a lot of other analysis, and they could not be included in this presentation just due to time restrictions. So our base case results for the cost effectiveness from these two models. We've got on the left-hand side the identification of the model, GSK and Merck. This is the live vaccine versus no vaccine scenario. And then the third column is the subunit vaccine versus no vaccine scenario. Calling your attention to the live vaccine results. GSK and Merck found $120,000 to $125,000 per quality-adjusted life year. This is a pretty close finding for two separately made cost-effectiveness models. Let's look at the live vaccine versus the subunit vaccine, and just look at the models independently. So in both models, GSK and Merck, the live vaccine scenario had a higher cost-effectiveness ratio than the subunit vaccine scenarios. Things get a little more interesting when we look at the subunit vaccines together, because the Merck model identified a cost-effectiveness ratio of the subunit vaccine of $74,000 per quality-adjusted life year, which is greater than what GSK found, which was $12,000 per quality-adjusted life year. The next section of this talk will be figuring out exactly why these two values are different. And we're going to start that discussion by looking at initial vaccine efficacy and waning of immunity assumptions. This is the initial vaccine efficacy from both models for a single dose and 2 doses of the subunit vaccine. We've got initial vaccine efficacy on the y-axis and age groups on the x-axis. The circle in red is the difference between the two models. The GSK model assumes a single dose of the subunit vaccine confers 90% vaccine efficacy initially, and the Merck model assumes it was 73%. Contrast that difference with how similar they are in the 2-dose assumption. So that was the initial efficacy. This is the efficacy through time. And the GSK model, again, is in orange, starts at 90%, which it was on the last graph, and then declines gradually until year 16. By contrast, the Merck model starts at 73% and declines to 0% after 1 year. For 2 doses of the subunit vaccine, the models are fairly similar for the first 5 years, and then the GSK model declines, the Merck model declines, but the GSK model declines at a more gradual rate. The next slide will get into what if we resolve some of these differences, what does that do to our estimated cost-effectiveness ratio? So we'll start by looking at the subunit versus no vaccine scenario. This is the GSK model base case result, which we've seen previously, $12,000 per quality. This is the Merck model base case result, $74,000 per quality. If in the GSK model they produced a sensitivity analysis where they manipulated some of their parameters in these ways. They lowered the second dose compliance rate, they lowered the first dose efficacy, and they increased the rate of waning following a single dose of the subunit vaccine. Doing this, changing these inputs, resulted in an increase in the cost-effectiveness ratio, bringing it a lot closer to what Merck did for their base case. And just to foreshadow a discussion later, this sort of sensitivity analysis is pretty common in these models. And I'm going to try to summarize in a later slide what a bunch of these simulation or a bunch of these sensitivity analyses would look like relative to the base case. But before I get to that, we'll talk briefly about their vaccine cost assumptions. Vaccine costs are very important for cost effectiveness in general. For the live vaccine, both models assume a comparable cost of about $200 per single dose. For the subunit vaccine, the GSK model assumes a single dose costs $140, and the Merck model assumes a single dose costs $106. When you account for the fact that there's 2 doses of the subunit vaccine, as well as vaccine administration fees, the total cost of the subunit vaccine in each of the models, total cost meaning the 2-dose cost, is $320 for the GSK model and $250 for the Merck model. Okay, so moving on to cost effectiveness in general. In this scenario, we're comparing the subunit vaccine to no vaccine. These are the base case results that we've seen before. $12,000 for the Merck, $12,000 for GSK, $74,000 for Merck. And what I did with the next click of the button is all of the sensitivity analyses, I identified the extreme values produced by them, and that yielded these error bars. And so this would be an extreme point in the sensitivity analysis from the Merck model, and this would be an extreme point from the sensitivity analysis of the Merck model. Okay, so there's 3 takeaways from this. 1, these error bars overlap. 2, even at their extreme points, they're all underneath $150,000 per quality-adjusted life year. And a final point, though this y-axis is truncated at 0, there were many sensitivity analysis simulations in the Merck model or in the GSK model that yielded cost-saving outcomes, but we don't present those numerically, but they were in there. Okay, moving on to the head-to-head scenario. So in these scenarios, we're comparing the subunit vaccine to the live vaccine, and we have our models identified here, our scenario descriptions. We have 2 base cases, 1 from each model, and then I picked out scenarios that most favored either the subunit or the live vaccine. First thing to notice is that in both base cases from both models, the subunit vaccine was found to be cost-saving relative to the live vaccine. The only case when the live vaccine was found to be cost-saving relative to the subunit vaccine was in a scenario in the Merck model that favored the live vaccine. Okay, moving on to summary and limitations discussion. So, in the base case, the cost effectiveness of the subunit vaccine versus no vaccine was between $12,000 and $74,000 per quality adjusted life year. Sensitivity analysis, this range broadened to cost to be from cost saving to $150,000 per quality gained. In the scenario of the live vaccine versus no vaccine, looking at the base case, the cost effectiveness was $120,000 to $125,000 per quality. Sensitivity analysis, and only Merck did sensitivity analysis on the live vaccine. The range was $60,000 to $260,000. In the head-to-head, which we just looked at, the base case of both models found that the subunit vaccine was cost-saving. There was one case where the live vaccine was cost-saving relative to the subunit vaccine, and that was in the Merck model with parameters that favored the live vaccine. So some of the important factors that influence the difference across models is that the items we discussed earlier, the efficacy of a single dose of the subunit vaccine and the waning efficacy of the single dose and the long-term waning efficacy of 2 doses of the subunit vaccine. Many other factors were also important in determining overall cost effectiveness. Those included vaccine cost, the regimen completion rate, HZ incidence, and the cost to treat a case with and without PHN. Limitations of the study, which we've already kind of covered, but they bear repeating because this uncertainty is out there. There's limited empirical data on several parameters, and the price of the subunit vaccine has not been officially published. With that, I would just like to say thank you very much for your attention, and thanks to all the teams and people who collaborated and helped me build these slides.
Thank you very much for that extremely clear presentation. Let's take some questions on this. Go ahead, Dr. Kemp.
First of all, a terrific presentation. Thank you very much. I think from what you said that the Merck base case assumed only one immunization. And so I'm not sure if this question is for you or for them, but that seems like, since it's licensed as a 2-dose vaccine, I don't understand the rationale for that. Can you explain that?
I can clarify a little bit. So in both models, they accounted for the fact that regimen completion may not be 100%. And so of the portion who did not complete their series, what would be the immunity for the person who just got 1 dose? That's what that immunity was about.
Dr. Hunter?
So follow up on that is, was there a criteria and a sensitivity analysis for various levels of completion? So, 0%, 50%, 100% of the population finished the 2nd dose.
Sure, there was. The base case assumption for 2nd dose completion for the Merck model was 73%, and for the GSK model, it was 68%. Their lower bounds, I think for both, were about 45%, and the upper bounds, I believe, were 90%, plus or minus 1 or 2.
Dr. Thompson?
Thank you. I just wondered if you could give us a little bit of intuition behind the different assumptions on the waning. They're very different behaviors. One looks like the first dose is just totally different curves there. So could you just explain a little bit why the companies are looking at this very differently? What's the logic? What's the evidence? Are they looking at the first dose as a priming dose? And what's going on in the assumptions that are in fact contributing to the big differences as in the 2 models on that factor?
Sure. I'll provide a comment on the literature as it stands, but then as to the motivation for the selection of their particular waning rates, I'll defer to the companies that are in the audience, I believe. So the literature on a single dose of the subunit vaccine, there is no data on what that efficacy would be. And so Merck based their result on some internal data, and, GSK based their result on internal data, Merck based their result on an assumption. And as to the motivations, that would be for either of the manufacturers to speak on.
Dr. Bresnitz, would you like to comment?
Sure, thank you. Just specific to that question, you're right, there are no data published for the 1-dose subunit vaccine, and so we basically had to guess or try to come up with some estimate. And the basis for our, and that was not just in terms of the 1-dose efficacy, but also the durability of that dose. And so the line that you saw on slide 16 or 17, I don't remember which one it was based on that, and it was really based on the phase 2 study results on the immunogenicity data that was published by GSK, which basically led them to, to basically do their pivotal trials with the 2-dose vaccine, and their phase 2 study showed that after 1 dose, they didn't get to what the peak was after 2 doses, and then after 3 years, it basically came down close to baseline. And so that's what we use to assess our durability of the, number 1 was what we thought might be efficacy, and number 2, what might be durability. Does that answer that question? Nancy?
Dr. Friedland, you want to comment also?
Absolutely. Dr. Friedland from GSK, thank you. So when we looked at our data, we needed to come up with an assumption for what vaccine efficacy would be for 1 dose, even though this is a 2-dose vaccine, and what the waning rates would be. So in phase 2, we had a study which looked at 1 dose. We were able to show that immunity was maintained above baseline out to 3 years, both for cellular and humoral immunity. And then in addition, we looked at what would the rate of waning be. And so here we took the assumption that why would the rate of waning be any different for the subunit vaccine versus the live vaccine? The live vaccine wanes at approximately 5.1 to 5.4% per year. So that was the rate that we put into our model for one dose.
Thank you. Other questions? Dr. Lee?
Thank you. That was a really nice presentation. And I think that some of my questions relate to things that probably you already have answers to that I just am interested in understanding. And one being, what type of models were built for these two different analyses? Are these Markov models? Are they Markov microsimulation models? So that's one question. And then also related to that is the time horizon for these models, over how long, and was discounting used for those models? And then I'll have another question for you.
Sure. So both were lifetime models, and they both did include discounting. I would call them both Markov models, and they actually did have, they did present simulation results, but I didn't summarize that here just out of the timeliness of it.
No, you did a great job presenting. And then I guess related to that is, so the estimates for the ZVL versus no vaccine were quite similar for the two, which I think was reassuring on one hand, but also because the assumptions might be different that go into those models. Did you look further to say if you would use the same assumptions about disease incidence, whatever other things that might come into this, is it the same result, or are they the same because they use different assumptions, just happen to get to the same result?
So to me, a lot of their assumptions were very comparable, very similar costs per case. Their waning immunity assumptions and efficacy assumptions for the live vaccine were super close. To me, it just looked like they relied on the evidence that was out there that was published, and they drew the same parameters or very similar ones.
Okay, and then I think the last thing that would be helpful might be, and maybe this would be in a different detailed document, but just understanding the price assumptions, which I think this will rest on, and then also just understanding what the ranges for sensitivity analysis were and whether or not PSA would be sort of typically used in this situation or these types of models, or if we would rely on sort of one ways to help us understand what the most like the sort of robustness of these analyses.
Sure. So I didn't present any PSA results. Both models did produce PSA results. When you look at the error bars that I constructed based on the one-way and scenario sensitivity analyses, those error bars contained, and this would be an estimate, but 80 to 90% of the PSA results. So that's one of your questions. The other question about price, the Merck model assumed a price parity for the subunit vaccine, they assumed a price parity with the live vaccine. And around that price parity, they expanded it plus or minus 20%, I believe. For the GSK model, they assumed a base case of $145 with an upper bound of $175 and a lower of $125, I believe. As to the motivation behind those ranges, that would be for the manufacturers to say.
Okay, thank you.
Dr. Reingold?
So just going back to the back and forth about the question of what the pattern of waning would be after vaccination and assuming a constant rate of waning, it seems to me the data that Dr. Klein showed were that at least for the one vaccine where we have a lot of data, that the effectiveness drops dramatically in the first year and then stays relatively constant after that. And so from a clinical protection point of view, it would seem to me that's a better model of what's going to happen than constant waning.
Dr. Brezhnitz?
Yeah, just I was going to make a comment on the one-dose issues, but we've already discussed that, so I'm going to limit it to the two-dose waning since it's relevant to this. I don't presume necessarily what my colleagues in GSK did in terms of plotting out the model for the two-dose durability, but it's been mentioned and actually presented at the last ACIP meeting, the 9-year data. And maybe that was what was applied to their model for durability after 2 doses. But I want to remind the ACIP here that data those data, were presented at the last ACIP meeting, and they were based on a phase 2 study. Those were not immunologic data that came from the ZOE studies, and it was immunologic data that involved 70 people in the phase 2 trial, a group that was homogeneous from Europe. So that is not representative of what was in the ZOE 50 and 70, and that's what's I think, being based on the model for the durability of the vaccine that goes out to 30 years. And the only other point I want to make is that the cost-effectiveness models that you did a great job in presenting. I mean, often we listen to this and sometimes it's hard to understand it, but you made it very clear. This is for 60 and over, but the policy question that was done in the great analysis today for Zostavax and also for Shingrix the last time was for 50 and over. So what we're seeing today is a 60 and over. And the last, just one other thing about that immunologic data goes out to 9 years. I mentioned it was presented last time. That is on the ACIP website. If you've lost your handout, you can go back and take a look at it. And when you look at that immunologic data, there is a drop, about a 4-4 drop from the response immediately after 2 doses to what you see at 9 years. And the bottom quartile of the point estimate at 9 years overlaps with the top quartile of the estimate at baseline. So there's no correlative protection, so I don't know that we can say necessarily anything about what the real durability is or the effectiveness is with that data, but it does really decline over time when you look at that. Thanks.
Thank you. Dr. Friedland.
Yes, thank you. So for the waning assumptions in the model, many of us don't have the full report that was submitted and reviewed by the CDC economic team, but the data for waning came from the ZOE 50 and 70 studies. And so the actual numbers are that the rate of waning for the first 4 years in people 50 to 70 was 1%, and then was 2.3% from years 5 and beyond. And for individuals over the age of 70, the rate of waning was 3.6% throughout the model. And those data come from the phase 3 randomized controlled vaccine efficacy studies.
Thank you for that clarification. I think it'll be really interesting to see the CDC model, having seen these 2 models, and then see how the decisions are made about the data used in the new model. I think we'll move on, if that's okay. Dr. Dooling?
Good afternoon, everyone. This will be the 6th and final presentation in the Herpes Zoster session this afternoon. I will speak to you about considerations for the use of Herpes Zoster vaccines. We'll start with a review of Herpes Zoster and post-herpetic neuralgia epidemiology in the United States. The annual incidence rate is approximately 4 cases of herpes zoster per 1,000 population, or that amounts to about 1 million cases every year. Incidence increases with age, ranging from about 1 case per 1,000 children to over 15 cases per 1,000 among those 80 years and older. For adults 50 years and older with herpes zoster, about 10 to 18% will go on to develop post-herpetic neuralgia. Similar to herpes zoster, incidence increases with age. For many, the pain of herpes zoster and the unrelenting persistence of post-herpetic neuralgia can be debilitating. So this is a graph of vaccination coverage of zoster vaccine live among adults 60 and older in the United States between 2007 and 2015. Starting from FDA licensure in 2006, Zoster Vaccine Live has shown a slow and steady increasing trend in coverage to approximately 31% by 2015. I'll not review the safety or efficacy, as you heard that information in detail in previous presentations. So this is a summary of the grading of the evidence for herpes zoster subunit vaccine that was presented to ACIP in February. In brief, the vaccine was significantly efficacious in preventing both herpes zoster and PHN. The estimates for vaccine efficacy against herpes zoster were 97% for individuals 50 to 69-year-old and 91% for those 70 and older. The estimates for vaccine efficacy against PHN were 91% for those 50 and older and 89% for those 70 and older. The protection against herpes zoster was at least 85% in the 4 years studied. With regard to serious adverse events, there was no difference detected between vaccinated and comparison populations. However, grade 3 reactions were more commonly reported among vaccinated compared to placebo group. All the outcomes examined were supported by type 1 evidence. The following are key herpes zoster vaccine policy questions before the ACIP. Question number 1, should ACIP recommend herpes zoster subunit for vaccination of immunocompetent adults, either as a category A or a category B? Question number 2, at what age should herpes zoster subunit be recommended to start, either age 50 or 60 years old? And finally, related policy questions regarding should ACIP recommend a preference for herpes zoster subunit vaccine over a zoster vaccine live, and should ACIP recommend that individuals previously vaccinated with Zostavax Live receive herpes zoster subunit vaccine? In order to address these policy questions, the remainder of the presentation will take the following format. First, I will present the workgroup interpretation of the data. Then I will present the deliberations on the policy options. The workgroup's current perspective on the policy will be shared. However, the workgroup is awaiting the final price for the herpes zoster subunit vaccine in order to finalize our cost-effective analysis, as you just heard about. In addition, we look forward to hearing for ways and strategies to achieve high 2-dose adherence to the vaccine. Therefore, only the interim perspective of the workgroup will be presented here today. With respect to the first policy question, should ACIP recommend herpes zoster subunit for vaccination of immunocompetent adults? The workgroup interpretation of the data is as follows. Based on one large phase 3 randomized controlled trial, herpes zoster subunit vaccine demonstrated the following benefits. There was high vaccine efficacy against herpes zoster, 97 and 91% for 50 to 69 and those over 70 respectively. There was high vaccine efficacy against post-herpetic neuralgia, 91% for people 50 and older. Additionally, the vaccine maintained high efficacy, more than 85% for the 4 years following vaccination among individuals 70 and older. Based on the same RCTs and additional smaller studies, herpes zoster subunit vaccine demonstrated no difference between vaccinated and comparison groups for serious adverse events. Grade 3 reactions, as I previously stated, were more commonly reported in the vaccinated group compared to the placebo. But what does all of this mean in terms of the burden of disease we can expect to prevent through the use of herpes zoster subunit vaccine? First, let's look at a simplistic scenario to explore this question. This slide presents health outcomes comparing herpes zoster subunit vaccine to no vaccine in a cohort of 10,000 60-year-olds over the course of 4 years. We've made the following simplifying assumptions: that VE and disease incidence are stable over the 4 years, and that all vaccinees completed 2 doses of the subunit vaccine. After 4 years under these parameters, we would expect approximately 320 cases of herpes zoster and 36 cases of post-herpetic neuralgia. If vaccinated with the subunit vaccine, cases expected would drop to 10 for herpes zoster and 3 for post-herpetic neuralgia, thus preventing 310 cases of herpes zoster and 33 cases of post-herpetic neuralgia over 4 years. Under these simplistic parameters, the number needed to vaccinate to prevent 1 case of herpes zoster in 4 years is 32, and the number needed to vaccinate to prevent 1 case of post-herpetic neuralgia is 303. Now let's look at the same health outcomes in the same cohorts. This time, however, the expected cases of herpes zoster and post-herpetic neuralgia are modeled over the lifespan of the cohort. A number of assumptions have been made regarding 2-dose compliance and 1-dose effectiveness of herpes zoster subunit, as well as waning of the vaccine. You were introduced to those assumptions in the previous presentation on cost-effectiveness analysis. The following estimates are derived from the Merck and GSK models. Estimates of herpes zoster cases expected over the lifespan in an unvaccinated cohort range from just below 2,000 to just above. Estimates of post-herpetic neuralgia cases expected range from 200 to 226. Estimates of disease in the herpes zoster subunit vaccinated cohort are much lower, as you can see. Thus, the difference between the unvaccinated and the vaccinated cohorts, or in other words, the expected herpes zoster cases prevented over the lifespan through subunit vaccination, ranges between 780 and 1,036, and the expected number of PHN cases prevented ranges from 70 to 112. Therefore, over the lifespan, the number needed to vaccinate to prevent one case of herpes zoster is approximately 10 to 13, and the number needed to vaccinate to prevent one case of PHN is 89 to 142. Returning our focus to the first policy question, should ACIP recommend herpes zoster subunit for vaccination of immunocompetent adults as either a Category A or a Category B? The workgroup deliberations were as follows. Based on a review of the grade assessment of the evidence for critical and important outcomes, the workgroup is confident that the vaccine is safe, efficacious, and maintains high protection against herpes zoster for the 4 years following vaccination. Workgroup members acknowledged the importance of clear ACIP recommendations. Under most assumptions, herpes zoster subunit vaccine demonstrates number needed to vaccinate and cost effectiveness either similar to or more favorable than other adult vaccines. The workgroup is favorable to vaccinating immunocompetent adults with herpes zoster subunit vaccine as a Category A. Question 2. At what age should herpes zoster subunit age-based recommendations start, either 50 or 60 years old? Workgroup interpretation of the data was as follows. Herpes zoster subunit vaccine efficacy is very high in the 50 to 59-year-old age group at 97%. There is minimal waning in the first 4 years following vaccine receipt. Waning beyond 4 years is unknown. In a small phase 2 study of participants 60 years and older, immunogenicity data at 4, 6, and 9 years following subunit vaccination shows similar CD4 positive T cell response with a greater than threefold rise above baseline. And this data was presented to the ACIP in February of 2017. However, there is no established correlative protection. Workgroup deliberations on this question included the following points. Herpes zoster and post-herpetic neuralgia incidence increases with age. In 2011, ACIP did not recommend zoster vaccine live for 50 to 59-year-olds because there was evidence of waning in the first 4 years and beyond. Herpes zoster subunit VE is very high in this age group with minimal waning in the first 4 years. The degree of waning beyond 4 years is uncertain. However, the durability has been demonstrated for immunologic outcomes, both cellular and humoral, at 6 and 9 years. There are approximately 42 million people who are 50 to 59 years old in this country, and about 21% of all herpes zoster episodes occur in this age group annually. Therefore, the disease burden in this cohort is significant. The workgroup is favorable towards a proposal for age-based recommendations to start at age 50. However, policy proposals are awaiting final price of herpes zoster subunit vaccine and accompanying cost-effective analysis for this subgroup. The next question considered was, should ACIP recommend a preference for herpes zoster subunit over zoster vaccine live? The workgroup interpretation of the data of these two vaccines is as follows. Please note that these vaccines have not been studied in a head-to-head efficacy trial. In terms of efficacy, the subunit vaccine estimates are higher than zoster vaccine live estimates across all age groups. Herpes zoster subunit appears to wane at a slower rate than zoster vaccine live over the first 4 years. With respect to safety outcomes, it should be noted that herpes zoster subunit has been studied in approximately 16,000 participants in preclinical trials, whereas zoster vaccine live has been administered to more than 20 million people in the United States following its clinical trials. Neither vaccine is associated with serious adverse events in immunocompetent persons. The subunit vaccine is more reactogenic than the Zoster vaccine live, and Zoster vaccine live is a live attenuated virus, which in fact can cause herpes zoster in rare circumstances. In terms of economics, herpes zoster subunit vaccine is more cost-effective than Zoster vaccine live under most assumptions that were presented today. This graph depicts vaccine efficacy and effectiveness against herpes zoster for herpes zoster subunit vaccine and Zoster vaccine live by age group during the first 4 years following vaccination. The horizontal axis is separated into 3 age categories. Efficacy for the subunit vaccine is depicted by the yellow bars, and efficacy for Zoster vaccine live is depicted in dark blue, and observational studies of the estimates of Zoster vaccine live are in lighter blue. As you can see, the subunit vaccine is more efficacious in each age category, and the difference is larger amongst older recipients. Let's return to the simple cohort of 10,000 people followed over 4 years. This slide presents the health outcomes comparing no vaccine, herpes zoster subunit vaccine, and Zoster vaccine live. We've made the same simplifying assumptions as previously, that the VE of disease and that the incidence are stable over 4 years, and that all herpes zoster subunit recipients had completed 2 doses. We've already presented what would be expected for the unvaccinated and the herpes zoster subunit vaccinated cohorts. After 4 years in a cohort vaccinated with Zoster vaccine live, we would expect approximately 115 cases of herpes zoster and 12 cases of PHN. Therefore, for every 10,000 people vaccinated, the subunit vaccine is expected to prevent an additional 105 cases of herpes zoster compared to Zoster vaccine live over 4 years. The subunit vaccine is expected to prevent an additional 9 cases of PHN compared to Zoster vaccine live over 4 years. And now let's look at those same 3 cohorts modeled over the lifespan. A number of assumptions have been made regarding 2-dose compliance and 1-dose effectiveness of herpes zoster subunit, as well as the rates of waning of both vaccines. And these, once again, were presented in the previous presentation. The following estimates are derived from Merck and GSK analyses. We've already presented the number of cases expected in the no vaccination and the herpes zoster subunit vaccination cohorts. Over the lifetime in the Zoster vaccine live cohort, estimates of herpes zoster and cases expected ranged from 1,600 to 1,640, and expected cases of PHN ranged from 140 to 177. Therefore, for every 10,000 people vaccinated, the subunit vaccine is expected to prevent an additional 360 to 715 cases of herpes zoster compared to Zoster vaccine live over the lifespan. The subunit vaccine is expected to prevent an additional 10 to 63 cases of post-herpetic neuralgia compared to Zoster vaccine live over the lifespan. To remind you, the 2 policies under consideration by the work group were a preference for herpes zoster subunit vaccine or no preference for either vaccine. I'll now go through the pros and the cons of each of these options as deliberated by the work group. Under a preference for herpes zoster subunit vaccine, the pros would be substantially more prevention of herpes zoster, post-herpetic neuralgia, and other complications. This is a particularly important issue for seniors 80 years and older who are most vulnerable and at highest risk for herpes zoster and PHN. The subunit vaccine is more cost-effective than Zoster vaccine live under most assumptions. However, the price has not been finalized and a cost-effective analysis is pending. The subunit vaccine is refrigerator stable, which may decrease provider barriers. Cons of a preferential recommendation are that the subunit may be removed from the market if an unexpected safety signal were to be observed. Next, this policy may lead to more grade 3 reactions following vaccination. It requires 2 doses, which will likely increase programmatic barriers. In terms of the no preference policy, this would support competition and safeguard a stable vaccine supply in the event of an unexpected safety signal. On the con side, large differences in VE will result in thousands of cases of preventable herpes zoster and hundreds of preventable PHN cases. Additionally, some insurers or delivery systems may choose to carry only the less expensive vaccine if no preference is stated. And finally, a non-preferential policy puts the onus on providers to compare safety and efficacy. Ultimately, there are a number of unknowns in this decision analysis. First, there is always the possibility that an unexpected safety event with herpes zoster subunit vaccine may occur. The vaccine effectiveness of herpes zoster subunit beyond 4 years is unknown. The real-world 2-dose compliance of herpes zoster subunit is unknown, and the vaccine effectiveness of 1 dose, as well as the durability of 1 dose, are both unknown. With regard to programmatic and implementation factors, the price is unknown, details of insurance provider coverage and health system carriage is unknown, and healthcare seeking among vaccinees with vaccine reactions is also unknown. So you may be asking yourself, as the work group did, how long will it take to answer the unknowns? Let's assume that the herpes zoster vaccine uptake continues at its current pace of about 3 to 4 million doses annually. To accumulate real-world safety data of herpes zoster subunit vaccine, a 1 to 2 year period may be sufficient for surveillance for rare adverse events. For 2-dose compliance of the subunit vaccine, again, 1 to 2 years would be needed, as compliance will likely change after program inception as the program matures and providers become more familiar with the reactogenicity profiles. As for effectiveness beyond 4 years, 4 to 8 year period beyond licensure would be necessary to study and report on long-term VE. And finally, the effectiveness of a 1 dose of herpes zoster subunit vaccine would require at least a 2 to 3 year period that would be needed to observe for an observational study in, for example, a large HMO that had at least 1 million unvaccinated adults to accumulate sufficient 1 dose recipients. At least 4 years would be required for estimates that were age-specific and duration of protection data. During this period, preventable cases of herpes zoster and PHN may continue to occur if a less effective vaccine is used. So, to recap, the workgroup deliberations regarding a preference for herpes zoster subunit vaccine over zoster vaccine live. The subunit can prevent significantly more herpes zoster and PHN than zoster vaccine live. Herpes zoster subunit is a more cost-effective than zoster vaccine live under most assumptions presented today. A preference would safeguard access for the more efficacious vaccine, whereas insurers or delivery systems may choose to carry only the less expensive vaccine if no preference is stated. An equivalent recommendation puts the onus on clinicians to review the literature on both vaccines to compare safety and efficacy. Finally, however, there are a number of key unknowns: 2-dose compliance, effectiveness of 1 dose, long-term waning, and the possibility of a safety signal. The majority of workgroup members favored a preference be stated for herpes zoster subunit over zoster vaccine live. A minority of workgroup members thought no preference should be stated at this time. The workgroup is awaiting a final price for herpes zoster subunit and accompanying cost-effectiveness analyses. And on to our final policy question for discussion today. Should individuals previously vaccinated with zoster vaccine live receive herpes zoster subunit vaccine? The workgroup interpretation of the data was as follows. Herpes zoster subunit vaccine is more efficacious than zoster vaccine live in all age categories. Experimental and observational studies indicate significant waning of protection from zoster vaccine live. The VE dropped significantly during the first year after receipt, and by 6 years post-vaccination, most studies estimate the VE is less than 35%. there may be negligible protection by 10 years post-vaccination. Herpes zoster subunit vaccine is significantly more efficacious over 4 years, with a VE greater than 97% in the first year, which is maintained above 85% in the subsequent 3 years. In a small study presented at ACIP earlier in this session, vaccination with subunit vaccine 5 years following zoster vaccine live did not alter the safety or immunogenicity of herpes zoster subunit vaccine. This graph depicts the vaccine efficacy against herpes zoster for zoster vaccine live and herpes zoster subunit vaccine by year following vaccination. In the red, you see the VE of herpes zoster subunit vaccine from the ZOE phase 3 clinical trials. In the blue is the VE of zoster vaccine live from the shingles prevention study clinical trial, and then the long-term follow-up of those vaccinees. As you can see from this graph, there is a significant gap in the herpes zoster protection between that provided by the subunit vaccine and that provided by zoster vaccine live. The workgroup deliberations on this policy question were as follows. Prior zoster vaccine live receipt should not be a contraindication to receiving herpes zoster subunit vaccine. For prior zoster vaccine live recipients, herpes zoster subunit is a new vaccine. A substantial amount of herpes zoster and post-herpetic neuralgia could be prevented by vaccinating this population with the subunit vaccine. Prior zoster vaccine live did not alter the safety or immunogenicity of the subunit vaccine. 31% of the US population, 60 years and older, has already followed ACIP recommendations and received zoster vaccine live. A significant fraction of those individuals now have very low protection, vaccine protection against herpes zoster and PHN. The workgroup's perspective was that herpes zoster subunit vaccine should be considered for people who have already received zoster vaccine live. The workgroup is awaiting final price for herpes zoster subunit and accompanying cost-effectiveness analyses. So that concludes our presentation on the policy question. Sorry, that concludes our presentation on herpes zoster vaccines considerations. Looking forward, in October, we will review a summary of the grade analyses of both vaccines, as well as a CDC cost-effectiveness model that you've already heard about. And indeed, considerations will be presented again. Also, an FDA licensure decision for herpes zoster subunit vaccine is expected prior to the ACIP October meeting. At the ACIP's discretion, a vote on herpes zoster vaccine recommendations may be taken in October of 2017. So my question to ACIP is, are there additional data that would help ACIP develop policy for the use of herpes zoster vaccine in adults? Thank you.
Thank you very much for that really excellent summary and presentation. Let's take some time for discussion. Anyone? Yes, Dr. Atmar.
At the meeting in February and also in the presentation earlier today, there were questions, or the question raised in February had to do with the racial makeup of the studies of the ZOE trials, where I think there was 1% Black or African-American persons included in the study. Today, with the revaccination, it was 100% white. So I don't know that we'll have the information by the fall, but I mean, this is still a big hole in terms of understanding whether it'll perform similarly in all groups.
Thank you for that comment. I think as you comment, the data that has been presented is the data that's been accumulated to this point.
Dr. Kemp.
In terms of additional analyses, what would help me, many of the analyses you presented today were really helpful and very straightforward, but your analyses relied on, or these analyses relied or assumed everyone getting 2 doses, and then the previous ones that we heard of earlier were based on 1 dose. I guess I'd kind of like to see these type of data for like 50% getting 2 doses, or, which I think is maybe a reasonable estimate, or 25%, at least a couple of major gradations there. That would help me.
Thank you. So just to clarify, I presented the cohort based over 4 years where everybody got 2 doses. That was what I referred to as the simplified cohort. The subsequent cohorts, which were modeled by both GSK and Merck, did assume real-world estimates or real-world estimates of what they expect to be 2-dose compliance in the real world. So as Dr. Leidner previously presented, for GSK, that estimate was 69% 2-dose compliance, and for Merck, that was 72% 2-dose compliance, and those did have sensitivity analyses around them as well, which weren't presented.
I have a sort of follow-up question to that, which is that in the sort of simplified cohort that you presented us, you used the 60-year and above, and I wondered why we didn't start at 50 if the recommendation of the work group was to start at 50.
So we wanted to use as much current real-world data as we could. So we modeled the current recommendation, but when we come back in October, the 50 to 59-year-old cohort will be modeled including cost-effectiveness analysis, so you can see that separately.
Ali, did you have a follow-up? Before
I just would like to see it a little bit lower than 75 or whatever, because I think that's a little potentially unreal.
Dr. Walter.
Chip Walter. Will there be any costing for revaccination scenario?
Yes, that costing will be done as well. Was provided by one of the manufacturers, but not presented due to time constraints. It will also be done in the CDC cost-effectiveness model.
Dr. Lee?
Just to address their question.
2 things I was going to ask if it would be possible to get follow-up on. One is, would we be able to see if Dr. Klein's data from today would make any difference in the outcomes of the models? That would be really helpful, at least for me. And then the other question I have is really around, to follow up on the disparities issue. I guess I'm trying to understand right now if there are any disparities that occur right now with regard to herpes zoster and post-herpetic neuralgia. And as we're making these considerations about preference, I start to worry that there may be some unintended consequences, particularly of things like if there are underinsured adults who may have to pay out of pocket. And so I just want to make sure that we've thought through some of those considerations to understand if cost does make a difference and if it's Medicare Part D, not Part B, how that might impact sort of the implementation of a program.
You bring up very good points. Currently, herpes zoster vaccine live is covered under Part D as part of Medicare, and we haven't received any indication that that will change if a new vaccine is licensed for that indication. To answer your first question, which was about the phase 4 studies out of Kaiser Permanente, Northern California, that data was used, in fact, to inform the longer-term waning of Zostavax in the Merck model. So that data has been utilized for that purpose.
Ms. Pellegrini?
This is just a picky data question, but on slide 12, you noted that the rate of herpes zoster among 50-somethings is 21% of the cases that occur?
Yes, that's what she said.
Right?
Yes.
Okay. I was wondering if you had similar data on PHN.
Less than, I can say off the top of my head that less than 21% of PHN will occur in this cohort. Raphael, I don't know if you can provide any other more specific information, data off the top of your head.
Not broken down for 50 to 59. The rates of PHN really accelerate once you reach the age of 60, and the number of cases, in fact, Dr. Schmader might have some information about that, but the rates of PHN amongst persons 50 to 59 is considerably lower than those in older adults.
Ken Schmader, AGS. I don't have any specifics other than what Raphael said. It's much, much lower.
Dr. Moore.
Thank you. To Dr. Kemp's point about 2-dose coverage, we did in the working group discuss extensively sort of what's realistic 2-dose coverage. There are reasons to, and we looked at things like hepatitis B coverage and completion of the series, but there are a couple of things to be encouraged about with respect to two-dose coverage in this population. And the group that we're talking about of 50 and over sees their pharmacist a lot, and the pharmacies are a source of immunization for that group. I, on my own, Googled how many people over 50 have a regular daily prescription, and from the data I found from 2005, it was 76% of people over 50 take a daily prescription, which means they're seeing their pharmacist very regularly, and I think the average number of prescriptions was 4. So I'm sure it's a lot higher now than it was in 2005, but that was just my quick search. But there are, in other words, a lot of opportunities for encounters with the healthcare community where immunizations can be given, in stark contrast to younger adults who are maybe at high risk for pneumococcal disease, or younger adults who are getting HPV vaccine, where we do definitely have harder challenges with getting them in and getting. So I'm hopeful that if there is a preference, that programmatically we can coach people and help create those programmatic opportunities to get those numbers up.
Dr. Foster?
Steve Foster, American Pharmacists Association. One of the major problems with getting patients vaccinated with Zostavax now has been the fact that the age 60 to 65 is not covered under Medicare, and many pharmacies have difficulty billing for those people. If we lowered this down to age 50, that's going to still, unless there's some insurance mechanisms that are developed along with this, it's still going to be a very difficult process for pharmacists to get coverage there.
Dr. Hunter?
So what I need information about to make myself not get crazy about this is during the first, 1 to 4 years after a recommendation is made, if we go with a preferential, what's the likelihood that we're burning a bridge and not going to be able to reverse that and still have the live vaccine available if there's something that goes wrong from an implementation and market share point of view?
Thank you for that question. I think that remains an unknown as well. I think from some of the informal qualitative outreach we've done, as well as we've heard from partners, there will be many clinicians who still want to give the vaccine with which they are most familiar and have experience with. So we intend that Zostavax would retain its Category A recommendation, and that clinicians would continue to have access to that vaccine. The distribution of market share under the case of a preferential vaccine recommendation would be hard for me to predict.
Dr. Reingold?
So I share the concern about not having much in the way of data in groups other than whites. Not to put too much on Dr. Klein's plate, but surely there are observational data both on the rates in different groups and on the vaccine effectiveness in different groups. So instead of controlling for race and ethnicity, you obviously could produce race and ethnicity specific vaccine effectiveness estimates, perhaps even if they had wide confidence intervals.
Noted.
Well, I think there's difficulty with the subunit vaccine. I mean, it's just the numbers are so small. Certainly possible for live vaccines. But other questions, Dr. Thompson?
Yeah, excellent presentations. I had a question about the framing of the cost-effectiveness analysis. So in the evolution of zoster vaccines, we have seen first the introduction of the ZVL, and in fact, that's widely used. So to me, that's currently the status quo. And really, I think if you're talking about changing the recommendation, the way to frame the economic analysis would be considering the new vaccine relative to that status quo. So I think that's kind of what was done in the head-to-head, except it would be better, in my opinion, to just do it much more directly. Okay. And then I think in that regard, I think some of the uncertainties, the unknowns you mentioned, those would be things that I think several of the ACIP members mentioned, would potentially be significant factors. And I think you could do some sensitivity analysis or uncertainty analysis around some of those with input from members of the work group to explore how that changes then that preferential, what the comparison looks like if you go from the current status quo to a subunit vaccine. So that's just one suggestion that maybe it's useful to look at it a little differently than the way the current cost-effectiveness analysis is framed. I think the second point, just coming back to the challenges with the uncertainty about how people will receive the vaccine, are there issues with side effects or adjuvant irritation or, anything that could change how people respond to that? I think that's obviously a big uncertainty that's really hard to guess at. But I think one of the things that triggers for me is that if you know that the vaccine feels different, behaves different, that would be a really important opportunity, and also a necessity for communication to make sure that you tell people why it's different, what it's doing, et cetera, because I think you have the opportunity to head off some of the potential issues if you work on that well. So I just encourage you to think about how the economic analysis might motivate you to also think through what needs to happen in the rollout.
Thank you very much for that comment. And I think you make an excellent point that two-dose compliance will be affected by many factors. One in particular is the ability to communicate with both public and clinicians about what's going to be expected following in terms of reactogenicity. So the work group is seized of that issue, and we will be working on it before we come back to you in October.
I'd like to go to the microphone. I know you've been waiting patiently.
I'm very patient. That was a very nice presentation, and actually my comments are related to programmatic and implementation issues and this issue of a preferential recommendation. As you know, ACIP rarely makes a preferential recommendation. You haven't done it yet for flu. You never did it for the HPV vaccine, and the last time it was done for LAIV, you had to go back on that for different reasons. It didn't have to do with adverse events. The safety database that we've seen with Shingrix, I think, is about 16,000 or so people. It's very similar to what we had for when Zostavax was licensed following the shingles prevention study. So that safety database is probably adequate for licensure, although I leave that to the FDA to make that decision. Zostavax has, it was said 20 or 25 million, experience in the U.S. over the last 10 plus years, but I can say globally it's 36 million individuals. And so we don't really know, with a vaccine like this, that's a novel adjuvant in terms of the target population and the dose that's being used, and in older individuals have comorbidities, we really don't know what the long-term serious adverse events will be. Clearly in the pivotal trials, there has been no difference with placebo, but we are seeing reactogenicity probably because of the adjuvant. And I just want to, when I was in public health, one of the first things I had to deal with when I was an state epidemiologist in New Jersey was the RotaShield issue, where it went to market, and then after a couple of million doses, it only took a couple of million because it was an acute event, immediately post-vaccination, and then we had to take it off the market. Now, there was not another vaccine at the time to replace it. I can answer, or I can speculate on the question of what would happen if there's a preferential to our vaccine. Demand will go down. It's clear. And so when demand goes down, production goes down. And for those of you who've ever had an experience in making a live attenuated vaccine, you don't ramp it up that quickly. And so as you go on with time, if some serious adverse event appears 1 or 2 years later, I'm not saying that it will, or necessarily that I would hope that it will. I'm just saying that it's hard to ramp up once you've basically reduced production. This issue is a series completion. Kathleen said that we included 73% in our model. We were asked to include 73% in our model. We don't think it's going to be 73%, but in deference to the CDC, they wanted to have a more comparable to what the GSK was developing, so we put that in as our base case. At that time, it was based on the Nelson paper, which is a paper looking at series completion for Hep A and Hep B. It was based on data that's more than 10 years old. Since then, there have been 2 publications, actually one by GSK that was just presented a month ago on this particular issue using Truven data. We also happen to have done the same analysis, and it shows that completion rates are less than 73%. So I think when you come back in October, I would urge you to use the more recent data that's been basically validated by 2 separate analyses sponsored by the 2 separate manufacturers. The insurance issue. you made a statement in your pros and cons, and it was great the way you did pros and cons. I agreed with most of what you had there, but not the issue of the insurance. And I talked to you about this, as you know, before the meeting. I don't really think that that's accurate, but I think we can check that. And when you think of insurance for Zostavax, you've got to put it in 3 buckets. It's commercial bucket, the Medicaid bucket, and the Medicare bucket. They're different in terms of reimbursement. My understanding under ACA, and perhaps I'm wrong, is that when it's recommended by the ACIP, it has to be covered by commercial insurance. There's not a preference for one over the other. It's got to be covered. Medicaid is not an issue because most states don't cover Zostavax. And with a parity, okay, I'm sorry. I'm getting the time signal here. And Medicaid has got to basically, included in their formulary, they just tier it. So since I got the time signal, I will wrap up. A preferential will make a difference here. And you haven't done it before, and I think that these 2 vaccines have different attributes. Let the market determine what's going to happen. There are advantages for one and there are advantages for the other. They're obvious. That's what happened with the HPV vaccine. You let the market dictate it. Cervix is not in the market anymore. Thanks.
Thank you, Dr. Bresnes.
Dr. Friedland?
Well, thank you.
And if you could keep your comments to 3 minutes, that would be great.
Absolutely.
Thank you.
So just to follow up on some issues around compliance and programmatic issues. So in the model that was presented earlier today, there were a wide range of sensitivity analyses varying second dose compliance and many other variables. And across all of the sensitivity analyses, the cost effectiveness is generally maintained across all of the various sensitivity analyses around compliance. I do want to say one thing around compliance and around preparing the patient for the experience of the vaccination around reactogenicity. I think that we can do great with second dose compliance. If we all work together, we're going to be discussing with the work group our plans to help bring education to providers, to the pharmacists, to the patients, so that we can have a benefit from the full vaccination series which this vaccine provides. So I think that our compliance rates, we have to put something into a model, but we can aim for higher, so we can get very high compliance rates with a vaccine which has a great potential to offer very high efficacy for people of all ages. Thank you.
Thank you. Okay, that was a fantastic, is there another question? Yes.
Hi, Mark Natoski, America's Health Insurance Plans. I just wanted to concur with the comment about payers and whether they can prefer one over another. If it is approved, then we would cover. I think the confusion often in the marketplace is that there may be variability in that year following approval, which plans may be adopting sooner versus later. So there's a bit of confusion in that first year. And I also think that when the physicians are evaluating their choices as far as physician preference, they may also choose to do a wait-and-see approach, and that may also limit access to patients that may wish to receive the newer vaccine. So I think there'll be a lot of variability in the marketplace as this comes into it. But from the health insurance plan, we would be providing both options. In the 50 to 60 range, it would only be the new vaccine that would be available if approved.
Okay. Dr. Belongia.
Just very briefly, just to add on to that comment, though, my understanding, though, is healthcare systems could, in fact, choose, big healthcare systems could just choose one product for a variety of cost and logistical reasons.
Yeah, I think that's true. Dr. Moore?
And in following up on that, those healthcare delivery systems now with so many quality measures might, in the absence of a preferential recommendation for a 2-dose product, might prefer themselves to go with 1 dose because it's easier to achieve quality benchmarks with 1 dose than it would be with 2. And so there may be pressure because of the way they're measured nowadays to do the easier thing rather than the more efficacious.
I hate to prolong this, but actually we've seen some real difficulty with pneumococcal vaccine in nursing homes because PPSV is considerably less expensive than PCV. And so despite the recommendations, people are getting PPSV first.
Just one additional comment, Mark Natoski again. Grandfathered plans may still be outside of this process, so they still exist.
Okay. Onward. Thank you very much to the Zoster team. This was really an excellent, excellent session. And now we're going to move on. We're actually going to postpone the anthrax vaccine work group report and go with the varicella. So Dr. Herpes.
Okay, good afternoon. Today I'm going to discuss the impact of the U.S. varicella vaccine program on the incidence of herpes zoster. Oop, sorry. Is that moving? Okay. In way of background, Dr. Edgar Hope Simpson was a brilliant clinician researcher in the UK during the post-war era. He developed a particular interest in varicella and in zoster, and while he had no formal training in epidemiology, he was a keen observer, and he drew many conclusions regarding the complex natural history of varicella, and which would still hold true today. Some 50 years ago, Hope Simpson published this hypothesis regarding the interactions of varicella and herpes zoster, abbreviated HZ. By 1965, there was evidence that zoster was caused by reactivation of varicella zoster virus, abbreviated VZV, present in latent form in dorsal root ganglia. Hope Simpson postulated that VZV reactivation occurred years to decades after initial infection, i.e., varicella, and that reactivation and subsequent development of zoster were under immunological control. He speculated that that control was maintained by two processes: by endogenous boosting of immunity, i.e. due to subclinical reactivation of latent VZV without the development of zoster, and by exogenous boosting of immunity, i.e. due to exposure to VZV to children with chickenpox. Decades later, in the early 1990s, as the ACIP and the FDA deliberated about varicella vaccination, they considered that if Hope Simpson was correct, the program would reduce VZV circulation and thus exposure, and the decline in exogenous boosting might then plausibly lead to an increase in risk of zoster. The same concern continues to make vaccine policymakers in Europe and elsewhere very skittish about introducing varicella vaccination even today. Here's an example of an early influential infectious disease model to evaluate the implications of the Hope-Simpson hypothesis by Brisson et al. Here's the key quote from the abstract. Mass varicella vaccination is expected to cause a major epidemic of herpes zoster affecting more than 50% of those aged 10 to 44 years at the introduction of vaccination, a very low-stated abstract. The next slide shows a key figure from this analysis: the predicted incidence of zoster in the general population following introduction of routine varicella vaccination. The y-axis shows zoster incidence, the x-axis shows years since introduction of varicella vaccination. An immediate decline in varicella rates is assumed in this model. As seen in the legend, the dashed horizontal line shows zoster rates assuming no varicella vaccination. The violet curve, representing the base case, assumes zoster risk is reduced for 20 years following exposure to varicella. And the two gray lines, representing sensitivity analyses, assume that zoster risk is reduced for either 7 or 41 years following varicella exposure. The base case model predicts that zoster rates will increase for the first 20 years after launch of varicella vaccination, peaking at levels about 50% higher than during the pre-vaccine era. Rates increase immediately and most rapidly immediately upon introduction of vaccination. Incidence then declines as fewer and fewer individuals remain latently infected with wild-type VZV. Numerous models have been published over the last 2 decades to evaluate the implications of the Hope-Simpson model. Most show that the results are qualitatively similar to these, with rapid increases in zoster rates immediately following introduction of varicella vaccination and peaking between 20 and 30 years later. It's now been just over 20 years since the ACIP first recommended varicella vaccine in 1996. I'd like to thank the committee for this opportunity to review the impacts of varicella vaccination on zoster rates in the United States. Having framed the issues, here's an outline of the remaining 15 minutes of my talk. I'll provide more background, starting with data on varicella burden, launch of the varicella vaccination program, and impact of varicella vaccination on VZV circulation. I'll then shift to zoster and zoster vaccination to provide context with which to interpret the key findings. Finally, I'll review zoster trends in the U.S. subsequent to introduction of varicella vaccination, the focus of the talk. I'm only going to be discussing zoster in adults since there's been no speculation that varicella vaccination would increase zoster rates amongst children born after launch of the program. However, I'll be happy to speak to this issue if there are questions during the Q&As after the talk. I'm going to close with some conclusions about the data. Okay, so let's begin by discussing the burden of varicella during the pre-varicella vaccine era. During the pre-varicella vaccine era, by young adulthood, almost all persons in the U.S. had evidence of prior infection. This is an indication that at that time, averaged over several years, an entire U.S. birth cohort of 4 million experienced varicella infection annually. Aside from serving as a source of exogenous boosting, these cases translated to the large burden of disease noted on this slide, which was the rationale for introduction of varicella vaccine to begin with. The varicella vaccines used in the U.S. are Merck's Varivax and Proquad, licensed in 1995 and 2005 respectively. Both are comprised of live attenuated VZV. In 1996, the ACIP recommended 1 dose of varicella vaccine for all children 12 to 18 months of age. The 1-dose program effectively prevented severe varicella, but school-based outbreaks persisted, so in 2006, the ACIP added a 2nd dose recommendation for all children at 4 to 6 years of age. Here are national data regarding varicella vaccine 1-dose uptake in children 9 to 35 months of age for the years 1996 to 2015. Percent uptake is in the y-axis, year is on the x-axis. By 2006 or so, uptake approached 90% in this cohort, and it was considerably higher at the age of school entry. Not shown here is that by 2012, uptake for the 2nd dose reached 88% amongst 7-year-old children, and this has since subsequently reached 94%. So how has all this vaccination affected varicella circulation? This graph shows varicella incidence as reported by 4 states that had continuous varicella reporting since 1990 or earlier. The y-axis shows incidence, the x-axis shows the year, the legend shows the 4 states. Incidence declined by an average of 97% between 1993 to 2014, ranging from 93% to 98%. This reduction obviously translated to huge reductions in the total burden of varicella disease, including hospitalizations, deaths, and outbreaks. In 1995, CDC established varicella active surveillance projects to more carefully monitor the impacts of the varicella vaccine program. This table shows the aggregated data for 2 sites stratified by age group. 98% declines in varicella incidence were reported by both sites. Indeed, circulation was already down by about 90% at the beginning of last decade. There were huge declines in all age groups, including infants under 1 year of age. Since infants are not eligible for varicella vaccine, the reduction in this age group was presumably due to the reduction in force of VZV infection, i.e. herd protection. So let's now move on to herpes zoster in the United States. So prior to licensure of zoster vaccine, zoster incidence was about 4 per 1,000 in the U.S. with an annual risk of 30%. Some of the burden of zoster is listed here, which you can read off the slide. I want to make brief reference to the risk factors for zoster for context. Age is the key risk factor for zoster. Risk varies by an order of magnitude across the age spectrum, and age affects everybody. Zoster risk is also markedly increased in immunocompromised individuals, up to 20-fold for some conditions. This group bears a substantial portion of the total zoster burden in the United States. Women are at 25 to 35% increased risk of zoster compared to men, regardless of age, and we don't know why. Caucasians are at 40 to 50% higher risk of zoster compared to African Americans. We presume it relates to genetics. And as far as genetics is concerned, family history appears to be a risk factor for zoster, but the fold increase in risk varies widely across different studies, from 2-fold to about 20-fold. A key point regarding zoster risk is my final bullet. Just as we don't have a mechanistic explanation for why VZV suddenly reactivates after decades of latency, we also don't know what distinguishes most individuals who develop zoster from those who don't. There's another major unknown about zoster. The incidence of zoster has been increasing for years to decades preceding the availability of varicella vaccine. This has been noted in 5 of 6 U.S. studies, and it involves all adult age groups. The obvious causes have been pretty much ruled out for these increases, and we have no explanations. Comparable increases have been seen prior to effective varicella vaccination in a number of studies, not all of them, but most studies, conducted in Canada, UK, Spain, Czech Republic, Taiwan, Japan, Australia, and Korea. This phenomenon obviously makes it a lot harder to interpret the impacts of varicella vaccination on zoster rates. Another factor that can complicate this determination, of course, is zoster vaccine itself. Merck Zostavax was licensed in 2006, was recommended by ACIP for adults 60 and older in 2008. In 2010, the FDA extended the Zostavax license to persons 50 to 59 based on additional clinical trial data, and we heard about that in the last presentations. But the ACIP has kept the age-based recommendation at 60 and older. We believe that to date, Zostavax has not had a substantial impact on population-wide zoster incidence for several reasons. First, uptake has been modest. Dr. Dooling in the last presentation showed this slide also. This figure shows data regarding zoster vaccine uptake in the US. The y-axis shows vaccine uptake, and the x-axis shows the year. Zoster vaccine uptake reached 31% in 2015 amongst persons 60 and older. In addition, as you heard in the prior session, you heard that vaccine efficacy for prevention of zoster is 51% for persons 60 and older, and it's much lower for the oldest cohorts. Also, that protection appears to wane to baseline levels at about 10 years. From a policy perspective, the key question for decision makers is not whether exogenous boosting controls zoster risk within certain households or in certain subgroups, but instead whether varicella vaccination leads to increases in zoster in the population at large. The U.S., with a population of 320 million, with an effective national varicella vaccination program lasting over 20 years, and with several sources of data regarding zoster incidence, is the ideal setting to test this question. This slide summarizes the information we have regarding the impact of varicella vaccination on zoster rates in the United States. There have been 7 U.S. studies showing zoster trends that include an adequate number of years of data following introduction of varicella vaccination to be informative. None of these 7 studies show evidence of an accelerating trend following introduction of varicella vaccination. In fact, 5 of the 7 studies actually suggest a deceleration, at least in certain age groups. Let's take a look at some of the most informative of these examples in the next few slides. So this graph shows data on zoster incidence in the y-axis for the years 1993 to 2014 in the x-axis. This is an update of data through 2006 that we published in 2011. Results for the last 8 years have not yet been published. These data are from market scan databases. These databases contain health insurance claims data on 230 million unique patients since the early 1990s, acquired from over 100 self-insured employers, state governments, hospitals, and health insurance plans, and Medicare in all states, and they represent current and former employees, retirees, and beneficiaries. The data cover persons 35 years of age and older, with ages stratified as shown in the labels. The figure shows a significant upward trend in zoster incidence in all age strata from the very start of the observation time, several years before varicella vaccination was introduced. While these data are unadjusted, our earlier published analyses, which showed almost identical patterns, were adjusted for sex, region, urban versus rural, and immunosuppression status. We also used a series of negative controls to assure that the results were not due to secular changes in health-seeking behavior or in case finding. Not only has there been no evidence that varicella vaccination and plummeting varicella rates contributed to increasing zoster incidence, but for persons 65 and older, rates appear to have plateaued starting around 2007. And as I mentioned earlier, it's not really feasible that this plateauing could be attributable to Zostavax uptake. Two other points. First, in our 2011 paper, to look for varicella vaccine impact on zoster incidence, we stratified the 50 states into states with high varicella vaccine coverage and low varicella vaccine coverage, and there were really no differences in zoster rates in these two groupings of states. Also, mean age at occurrence of zoster did not change over time. If exogenous boosting was important, one might speculate or predict that mean age would have declined in the absence of exposure to varicella, but that did not happen. The age stayed stable. Now let's look at another analysis. This graph shows zoster incidence by age for 1992 to 2010 amongst Medicare beneficiaries 65 and older. These results were published in 2013, and they're adjusted for all key variables. And we also use negative controls to look for secular changes in health seeking or case finding. These results amongst older adults are very similar to those that I showed in the last slide, with a large increase in incidence amongst all age strata from the very start of the study, starting several years before licensure of varicella vaccine. These results also provide no evidence that varicella vaccination has contributed to an increase in zoster incidence, and they also show that plateauing phenomenon beginning in 2007. In this study, too, zoster rates did not vary across states with high versus low varicella vaccination uptake, and also median age at the development of zoster remained stable throughout the entire observation period. We recently extended this data, this analysis to 2014. The results haven't yet been published, and they're shown on the next slide. These are unadjusted aggregated data for Medicare beneficiaries 65 and older. The abrupt plateauing we saw in the last slide continues. In fact, rates appear to be declining. As I noted earlier, it's not feasible that uptake of Zostavax could be bending the curve so abruptly in 2007. Here are data presented at ID Week last October regarding age-specific zoster incidence between 2000 and 2014 amongst the 5 to 6 million veterans who received their health care in the VA system. The authors reported that by 2015, Zostavax uptake was just 6% in persons 60 and older and just 5% in people 50 to 59. The authors noted that zoster rates stabilized in recent years after years of increase and even decreased significantly in persons 60 to 69. Once again, surely no indication that varicella vaccination has led to an increase in the incidence of zoster in this population. The VA population and healthcare system are quite different from those of MarketScan and Medicare, so the consistency of our findings across these different platforms suggests that they're really robust. So in summary, there's not been any evidence that varicella vaccination has led to a noticeable increase in zoster rates in general, in the general U.S. population. Well, why might that be? So there are several categories of explanations. First, the Hope-Simpson hypothesis may be wrong. VZV exposure has little or no impact on controlling zoster, or any impact may be short-lived. Or perhaps subclinical VZV reactivation and endogenous boosting compensate when exogenous boosting declines. Second, maybe there were too few VZV exposures during the pre-vaccine era to noticeably alter zoster rates at the population level. The effect may have been limited to smaller subgroups like parents of young children or occupational healthcare workers. Or perhaps the population burden for zoster is concentrated in older adults who have few VZV contacts and who may also respond less robustly to exposures due to immune senescence. Third, perhaps Hope Simpson's hypothesis partially manifests as a reduction in the mean age at development of zoster due to less exogenous boosting. Zoster tends to be milder in younger adults, so they may be less inclined to seek care, masking any effect. It would be hard to rule out that possibility, but there's also no evidence to support that it's true, and there's soft evidence to suggest that it's not likely. Fourth, some might suggest that it's too early to see an impact of our varicella vaccination program. One could argue that it's only been 12 to 13 years since rates of varicella have declined by 80% or more, and that more years are needed to see an effect. However, most models, as I pointed out earlier, most models predicted an effect much sooner than 12 years, and in household studies suggesting that exogenous boosting reduces the risk of zoster, the effect is immediate. Finally, maybe all the U.S. studies are wrong, and a true zoster incidence is being missed due to overriding artifacts or to across all sites and all study designs. Data on zoster rates after introduction of varicella vaccination have also been published for Australia and for Canada. To date, the Australian data are somewhat hard to interpret because of a lack of data on baseline trends, and because public varicella vaccine programs in Australia were introduced more recently in 2005. Regarding Canada, varicella vaccine was marketed starting 1998 to 1999, but publicly funded programs were launched much later on a province-by-province basis, so duration of follow-up is still not that long. Studies have been published for 4 provinces. 3 have shown no evidence of acceleration of zoster rates. There's a study that just came out literally 2 weeks ago from Manitoba that does suggest there was an abrupt increase in recent years. So in conclusion, what are the impacts of U.S. varicella vaccination? In terms of varicella, incidence, outbreaks, and severe disease have all declined to record low levels in all age groups. In terms of zoster in children, rates have declined to very low levels, although I haven't presented data to you on this aspect. In terms of zoster amongst adults, there's no specific evidence that the varicella program has increased zoster rates in the general population. The epidemiology does seem to be changing, and we can't explain why, just as we cannot explain what distinguishes persons who experience zoster from those who don't. In theory, it's possible that the U.S. data have not resolved an increase, either because we're not powered to see a small increase or because more time is needed to see an effect for some reason. This seems unlikely, but regardless, at a minimum, models can be updated and constrained using our U.S. data to allow for more realistic evidence-based assumptions regarding varicella vaccine impact. Finally, the U.S. experience can provide reassurance for countries considering adoption of varicella vaccination. And that concludes my talk. I'll take any questions.
Thank you very much. That was a great talk. Questions for Dr. Herpes? It's Dr. Thompson.
Fabulous presentations, really great to see all this data put together in one place. One question on the, you had a slide on HZ rates by age, that was the VA data that you said was just recently presented with the very low annual, so could you just say a little bit more about what that slide is actually presenting? And I guess one of the things I'm getting to is...
this slide?
Yes. That one, exactly. So, yeah, so maybe you could tell me exactly what that's showing. Is that the number of people in that age group in the VA who are given the vaccine during the year?
No, this is individual. Well, they present that only 6% of individuals had received Zostavax of this population, 60 and older, and only 5% of people 50 to 59. And so this is essentially a naive, if you will, population. Does that answer your question?
Yeah, thank you. I just wasn't clear.
Other questions? Dr. Reingold.
Just a comment, Raphael. It seems to me you're preaching to the choir. You should go give this talk in England.
And we hope you will.
I won't comment on that.
Yes.
Just for amusement, I wanted to mention that a French friend of mine did a study in sequestered monks, which Raphael will remember. in which he showed that there was no increase in Zoster in those sequestered monks who had never seen children by and large. So perhaps that should remind the ACIP committee that modeling is supposition, epidemiology is fact.
Thanks, Dr. Plotkin. I'm told
Thank you,
that.
Dr. Plotkin. We will be quoting you often.
Thanks, Dr. Plotkin. And I'm also told that that population had a very low rate of genital herpes as well.
Oh, and thank you for that. Thank you so much. That was a great presentation. I think we're going to move on to vaccine supply, and Dr. Santoli is ready.
Hi there. I have a very brief update for you all this afternoon. I'm going to talk a little bit about hepatitis B supply, and then just remind you again about our vaccine supply shortage page on the website. So with regards to adult hepatitis B vaccine, Merck is not currently distributing its adult hepatitis B vaccine and will not be distributing this vaccine through the end of 2017. The dialysis formulation of their hepatitis B vaccine, however, is not affected by this. And GSK has sufficient supplies of adult hepatitis B vaccine to address the anticipated gap in Merck's adult hepatitis B vaccine supply during this period. However, preferences for a specific presentation, for example, a vial versus a syringe, may not be met uniformly during the time period. And then just a reminder that we update the CDC website on the vaccine supply page every time we do an update at one of these meetings or in our monthly vaccine supply stakeholder calls. And that concludes my presentation.
Thank you very much, Dr. Santoli. That was the fastest yet, I think. Any questions for Dr. Santoli? We can drag this out after all, right? Any questions? Seeing none, thank you. Okay, we're going to move on to public comment, and Amanda, will you?
We have one person who is registered for public comment for this afternoon, and Ms. Woodruff, Ms. Andrea Woodruff, please.
Thank you. I'm here to request that all de-identified data, as well as models, and I mean full models, not models referred to in parts in a paper or partially presented, but the full model be, along with the corresponding data, be publicly available. And that you ensure that statistics are presented here at these meetings are statistically significant with widely accepted statistical methods. Essentially, I'm asking that you ensure that you aren't using snapshot data, but full picture data. Formerly, I worked for one of the largest vaccine manufacturers selling vaccines. Afterwards, I interned at the Senate's Health Committee following vaccine legislation. Additionally, I worked for the Council on Foreign Relations doing corporate fundraising that included vaccine manufacturers. I am not anti-vaccine. I couldn't be better trained to be pro-vaccine. However, it became impossible to ignore that our current vaccine vetting process hurt me and my family. While I am pro the concept of vaccination, I believe in transparency with data, models, and statistically significant information and presentations. I now own a company that does applied analytics, specifically operations research. I wanted answers to questions that were not adequately provided. In order to start getting used to the data, I started by asking, do increased vaccination rates decrease vaccine preventable disease? I thought this would be easy. Surely the data would be publicly available and prove that this is so. Everyone I spoke to at the CDC seemed to think this was available, but when I went to go look for the data, I essentially found snapshot reports with incomplete data and it was not downloadable. Nothing was convincing when I looked at it critically. We wrote 7 models on GitHub. GitHub is a public repository for models and data that use linear regression, autoregression, and Bayesian hierarchical models. I have no financial interest here. I have provided the work at no cost publicly to be criticized publicly, to ensure common understanding and to get some answers for myself and my family. We had problems accessing MMWR data, so we used WHO data. My tax dollars were used to gather MMWR data and to collect all the data, actually, that the CDC uses. So why don't I have access to it? Please listen to me. Nothing showing that the higher the rate, the vaccination rate, the lower the disease incidence was statistically significant in the United States. Nothing that we've run so far. If you are making recommendations, you should have downloadable data that is publicly available to anyone to check the work that is being done here. Thank you.
Thank you very much. I know that the CDC has been working with you and will continue to do so, and we appreciate your comments. Seeing that we have no further comments, I think we're done for the day. And we will start tomorrow at 8. I know there was some confusion this morning. Tomorrow morning we will start at 8 with the agency reports. Thank you all and have a good evening.